Bismillah ar-Rahman ar-Rahim. Good morning, everybody, and welcome. I'll start by thanking the organizing committee for this brilliant meeting and an excellent attendance, mashallah, tabarakallah. And I even heard that the attendance in the first day was superb. My topic today is quite challenging. And one of the reasons for it being challenging is the title itself. When I took the title initially, after starting preparing the slides, I come to discover that the angles that I'm supposed to be covering are so wide. So start thinking there are so many aspects of nosocomial infections, of healthcare-related infections that has to be covered, and it is almost impossible to cover them adequately in 45 minutes. The nutshell is, in these slides, there would be areas that definitely need to be looked at by whoever is interested. There is a reality and there is expectations when you present in 45 minutes with such a topic. I'll try my best to meet, hopefully, some of these expectations. And I'll guide you, or I'll tell you what are the things that I'm not going to be talking about from the beginning. So I'm not talking to you about epidemiologies of nosocomial infections because there are so many of them. And truly, I do not have a national data in Saudi Arabia as well. We have a lot of data from US, from Europe, but the accuracy of national data from my point of view is a little bit of a problem, so I don't think I want to comment on that. I'm not going to be talking to you about how to stop nosocomial infection because this is a whole conference by itself. And I'm not talking to you about antimicrobial stewardship, and I'm sure somebody must have talked about it yesterday. I'm not talking to you about how desperate we are when it comes to drugs, especially in my area, in the critical care units, and the fact that we have so many bugs with very, very limited amount of drugs available for us. I'll leave you with one slide. Hospital-acquired infections are medical errors. They are not anymore mishaps. They are not anymore something that can happen in any place in all hospitals. In a recent conference in 2012, up to 30% of 33% of death in 2009 were due to preventable medical errors. We're talking about US and Canada. I don't have a record, don't have numbers here, but my gut feeling that the numbers would be probably a little bit higher across all the hospitals, including quote-unquote tertiary care hospitals. What we're going to be discussing are cases. There will be few cases that we will go through, and we hope to enlighten you during this presentation on these cases. They reflect a little bit of management issues. Some of them are straightforward. Some of them may need further discussions. I will start with my first case. You are called to see an 80-year-old male with fever for the last 48 hours. He's diabetic, on oral hypoglycemic, he's hypertensive, and he has atrial fibrillation. This guy was admitted 14 days ago through ER with a diagnosis of acute MCA stroke. He was admitted to general critical care unit for 3 days initially for monitoring, and then he was discharged to the floor. Last 24 hours is significant, last 48 hours is significant for fever and shortness of breath. His current medications, aspirin, Lipitor, and low molecular weight heparin for prophylaxis, DVT prophylaxis. History is short, typical of the ICU type of history we get. Slightly confused, dense right-sided hemiplegia, respiratory rate 28, heart rate 110, temperature 38.9, blood pressure is 150/85, saturation 88% in room air and improved after giving oxygen, cardiovascular examination within normal, chest examination, few bilateral basal crackles, right more on the left. The abdomen, slight mild left-sided lower quadrant pain, no rebound, no guarding. Foley's catheter in place for the last 12 days. Peripheral vascular access he has and looked fine. Nasogastric tube is in place. How common do you see this presentation? Every day. Good. You're not different. What is the diagnosis? Would you call this hospital-acquired pneumonia? Would you call this hospital-acquired urinary tract infection? Would you consider this hospital-acquired aspiration pneumonia? Would you think there's an intra-abdominal sepsis? Would you think this is an aspiration pneumonitis? Straightforward. No complications. Nothing behind the lines, between lines. What would you call this? Who would choose one? We'll call it a HAP. Who would say it's a UTI? Possibly. For 12 days. Okay. Who would say this is a hospital-acquired aspiration pneumonia? A little bit more people. Most of the people are shy to give answers. Who would call this a pulmonary embolism? No one. Who would call this is intra-abdominal sepsis? Okay. And who would say this is an aspiration pneumonitis? Okay, so most of the people will go for hospital-acquired aspiration pneumonia. This is the chest X-ray, which showed an infiltrate for right lower lobe, confirming your diagnosis of a pneumonia, and the correct answer is what you gave, straightforward. This is hospital-acquired aspiration pneumonia. Now, what other investigations would they request for? Sputum, everybody would probably agree with. Blood cultures, CBC, liver function test. Somebody might want to get an ABG to see how sick the patient is. Somebody would like to get a serum lactate in the presence of a normal blood pressure. Probably that's not really needed. Urea and creatinine will be good to sort of evaluate the dosing of drugs that you might want to give. Now, what is the blood culture yield in such a patient? Do you think it's 20 to 25%? Do you think it's less than 5%? Do you think it's less than 12%? Do you think it's anywhere between 12 to 15%, 16 to 25%, more than 30%? 12 to, okay, who goes for the first, the extremes? 20, 25, more than 30? Nobody. Less than 5%? Less than 12%? Few people. 12 to 15? More people. 16 to 25? More than 30%. I will give you the answer, and I'll give you some evidence for it. It's less than 12%, and in fact, it's even less than 10%, sometimes up to 5%. The blood culture or the blood culture yield is quite low. It's quite interesting that the blood culture, if you look at any lab, we looked at our lab, and see the amount of blood cultures being requested for all type of infections, specifically pneumonias. People are still requesting blood cultures for community-acquired pneumonia, even for patients who are discharged from ER. That's not a recommendation anymore. People admitted to the hospital, the yield is also questionable, except in very few conditions in which the yield becomes a little bit higher, immune-compromised hosts, people on previous antibiotics, people with lines, stuff like that. But generally, yield is low. We even looked at, in our hospital, the blood culture yield among all admissions with pneumonia to the ICU, which all the guidelines still mention that you have to do blood cultures on. And the yield there is also not high. There are some patients, populations which you really want to do blood culture for, but a lot of patients actually do not need. We ended up having in microlab like 1,000 blood cultures being requested and something like 5-7% yield, even among those admitted to the ICU. So you need to still follow the guidelines at the moment, but I think this area might change in the future.
The value of the sputum culture should be very misleading. You have no other option, right? Microbiological option. You either have sputum culture or a blood culture. Sputum could be highly contaminated specimen.
True.
I think it still holds that we should draw a blood culture when it's suspected.
The statement I said is you're going to still follow the recommendations. However, I think the cost of running a blood culture on a lab is so huge. And if you keep on bombarding the lab with all blood cultures, especially among the first groups that we mentioned earlier, which is the patients not being admitted or patients who are less sick, admitted with pneumonia to the general medical floor with an expectation of 24 hours sort of a discharge, then you're probably going to be doing, you are really overdoing it. But if you try to select more patients, sicker, elder, immune compromised, multiple batchy pneumonias, you're probably going to have a better yield than what we are currently practicing. Our practice right now is more of a knee-jerk reflex. Fever, pneumonia, blood cultures. And this is what we try to, people need to be a little bit critical about. Establishing a terminology of aspiration pneumonia as compared to just HAP, because everybody or most of the people have selected aspiration pneumonia. What does it mean in your mind? Does it mean anaerobes are important pathogens in causing this pneumonia? Who votes for that? Okay, I really thought somebody's going to vote for that. Either clindamycin or metronidazole has to be part of the antibiotic coverage. Okay, so terminology has no therapeutic implication. Rather, it establishes the mechanism of development of pneumonia for further prevention. Okay, terminology has therapeutic, prognostic, and preventive implications that vary between patients. So, which one? There has to be one, guys. Both 2 and 3. Okay. 3 and 4. 2 and 4. Okay, somebody picked up clindamycin. There has to be somebody who's going to pick clindamycin. Okay. Now, this is my choice. We're going to finish some of the slides, and you're probably going to have an idea of what we're going to be talking about. Arba. Okay, let me try to explain to you a difference between, which probably you know already, aspiration pneumonia and aspiration pneumonitis. Aspiration pneumonitis is basically a syndrome by which there is a chemical injury that might lead to fever, infiltrate, even ARDS in patients, and there is no involvement, there is no infectious process involved. While aspiration pneumonia is an infectious process caused by the inhalation oropharyngeal secretion that are colonized by pathogenic bacteria. So there's a distinct features between the two. In the beginning, when you aspirate, a massive aspiration, typically after OR, the first phase peaks about 1 to 2 hours after aspiration and result from the direct effect of the aspirates on the cell lining. It may proceed. The second phase, which peaks in 4 to 6 hours, is associated with infiltration of neutrophils into the alveoli and lung interstitium. This is something we commonly see in trauma patients. They come to you in the emergency room, they go to the OR, and they come to you with an ARDS-like pictures. So they must have aspirated in between. Bacteria in the beginning do not have a major role, simply because the gastric content is quite acidic. So it doesn't allow the growth. Now, if you change the pH of the stomach, because of drugs, because of nasogastric tube, because of previous obstructions, because of these type of things, you're going to be talking about a little bit of a different story here. This slides basically explain the differences between, goes into the differences between them. Aspiration pneumonia, now we're going to be talking about aspiration pneumonia, not anymore aspiration pneumonitis. Responsible for 7 to 25% of CAP cases, 18% of nursing home acquired pneumonias, 10% of patients who are hospitalized after drug overdose, 10 to 30% of all deaths in the anesthesia. This might be a little bit on a higher side because the data are coming, especially on the last one, from an older paper. Important for residents to remember, right middle and lower lungs are the most common sites of infiltrate because of the right main bronchus being large caliber and more vertical. Classical exam questions. True or false? Risk of aspiration pneumonia is lower in patients without teeth and with aggressive oral care. Good. In recombinant position, the most common site of involvement are the posterior segment of the upper lobe and the apical segment of the lower lobe. Okay. In upright or semi-recombinant position, the basal segment of the lower lobes are usually affected. True. These two are very important. I'm mentioning them more of an educational thing rather than a questions. You have to remember one thing. The aspiration differs with the patient's position. So you cannot look at the X-ray and say, well, it doesn't look right because this is not the site where the aspiration occurs, because you have to remember the positions of the patients first to be able to identify whether it fits or no. Anaerobes are the main etiology for community aspiration pneumonia, but less in hospital aspiration pneumonia. Maybe. Okay, this was false. We're going to see this in the coming few slides. Yes, aspiration pneumonia is the most common cause of death in patients who are fed by gastrostomy tube. True. Severity of lung injury is not proportional to the volume of aspirate, but how low is the stomach pH? Wrong. It's actually proportional to both. The larger the volume, the more injury. The lower your pH, the more injury. PEG is more effective than nasogastric tube in feeding and delivering nutrition, but is not superior to nasogastric tube in preventing aspiration. True, good. Incidence of aspiration pneumonia with post-biologic tubes has been shown to be similar to that of intragastric tube. Post-biologic feeding, jejunostomies versus gastrostomies. The same or post-biologic is better? Same, they are the same. They are the same, yes. Feeding tubes offer some protection from colonization of the oral secretions. They do not offer protections. In fact, they invite more colonization, so they are harmful. Bacteriology of aspiration pneumonia. Now, this is the bulk of this. What are we dealing with when we talk about aspiration? This is a very recent article, 2013, and it actually tried to address this particular question. How important are anaerobes in the aspiration pneumonia? The problem is anaerobes are very fragile, fastidious, slow growing. In order for you to grow them, you need to have uncontaminated samples. And uncontaminated samples would need transthoracic needle aspiration, transtracheal aspiration, or doing it by bronchoscopies. The methods, and then you also need to go through a very tedious methods in the lab to try to grow these organisms. They take longer time. Something or a practice that we don't do very frequently. We are not really very invasive at the moment in the ICUs. No, when I start my training, we were doing bronchoscopy for everybody. Nowadays, we just really rely a lot on the endotracheal cultures rather than having an invasive procedures. In the 70s, there was so much interest in trying to isolate anaerobes. And if you look at the literatures for 70s on the aspiration pneumonia, you find people reaching up to 62%, 100%, 87%, and 93% labeling this pneumonia due to anaerobes. That was in the 70s. People were doing all these fastidious things, all these tedious things, bronchoscopies, and going through the lab. And based on that literatures, in the past we used to say aspiration pneumonia is really linked to anaerobes. And it was part of the recommendation comes that clindamycin, flagyl, anaerobic coverage has to be part of, or beta-lactams with penicillin has to be part of the coverage for all type of anaerobic or aspiration pneumonias. And bacteroids, fusobacterium, and peptostreptococci were the commonest organism identified. Recent papers, however, from different populations, microbiology and prognostic factors of hospital and community-acquired aspiration pneumonias in respiratory intensive care unit, now are not really showing a lot of anaerobes being involved. Most of the isolates, 60 to 70% of the isolates are aerobic gram-negative organisms rather than that. A very nice paper by Canadian groups that actually took all the comers to the hospital and classified them into two groups. People with community-acquired aspiration pneumonia, we see every day, and patients with an aspiration pneumonia, but they are coming from a continuous care facility. They're not the hospital patients because we've seen the hospital subset, but they are coming from continuous care facility. Look at some of these data, it's very important. First of all, how serious is this problem? Community-acquired aspiration pneumonia. 30% will require admission to the ICU when you compare them to the people who are coming from continuous care facility. Now this could be, part of this could be because people with the continuous care might be labeled as a no-code, less aggressive care and stuff like that. But the most important is that this is a very serious condition and can lead to significant admission to ICU and bed occupancy for you. And mechanical ventilations in around 30%. Some of the risk factors, vomiting, decreased level of consciousness, were more seen in patients with community-acquired aspiration.
Can you go back to the previous slide? Just have a question. The previous one.
This is
saying fungi are second to gram-negative as well as community and hospital-acquired pneumonia?
this is what they found. Now, yes, the fungi are probably just a colonizer. Yes. No, the fungi are probably because Candida pneumonitis is very rare. The only isolates or the only time is you think about it, severely immune-compromised people with bone marrow transplant, lung transplant, this type of a patients. Yes.
I thought something changed, so still it holds.
No, it still holds the same thing. The second slide that looks at the same thing, community-acquired aspiration pneumonia and patients with community-acquired non-aspiration pneumonia. And strikingly, again, there's a major difference in admission to the ICU. 30% with those with an aspiration pneumonia would require admission to the ICU because they are sicker, compared to only 8% of patients with community-acquired pneumonia, non-aspiration. So this is really a serious illness that people need to be looking at, be aggressive in addressing it while patients in the hospital. We're going to be talking about that in a minute. Now, the blood culture yield. Look at the mortality and the blood culture yield. Mortality is around 20% in the aspiration pneumonia group from community, compared to 7% in the patients with CAP, but they're non-aspiration. Blood culture, they've done huge amount of blood cultures number from those patients, and the yield is around 11.8, and the yield for non-aspiration is only 7.6. The group of organisms, Staph aureus, Strep pneumoniae, and E. coli predominate the aspiration pneumonias in both groups. They are present in both groups, gram-negative and gram-positive. The anaerobes were not really a major pathogen. Same, continuous care facility acquired pneumonias compared to patients with continuous care facility acquired non-aspiration pneumonia. The same thing applies. Mortality is quite high. Intensive care admission is quite high in the aspiration group. So aspiration is a major risk for a bad outcome. Blood cultures is also low, 4.7% and 6.7% on both groups. So the blood cultures yield in this group of population, it's still not that great. We do a lot on those patients, and we probably need to come with some sort of a system by which we grade our patients to try to reach a balance where you balance your expenses for a better outcome. Conclusion, there's also another recent paper. Now this one looked at PCR. So what they did is they took all those patients with an aspiration pneumonia or community-acquired pneumonia in general, and did PCR in the blood, they did PCR in the sputum, and they did PCR in the urine, looking for etiologies. And they could come up with a gram-negative, aerobic gram-negative organisms in around 90% of the cases. They can pinpoint this organism among the aerobic gram-negative with one of these methods supported by a PCR. They would still do the routine blood cultures, urine cultures, and everything, and then they supported that by a PCR. The conclusion of this, what I want just to tell you is, based on that, we do not think that the anaerobes are any more responsible for most of the cases of aspiration pneumonia. And as such, we have to keep that in mind. Not every patient comes with aspiration. You put in clindamycin and flagyl. Now, whether this is a change of organisms or this is simply because of a better understanding from our side, it remains speculations, because there were older data to show that they were isolated before. They could have been contaminations, they could have been colonization, they could be part of the flora and may not really be responsible for infections. And we see this on daily practice. You treat with non-clindamycin and non-flagyl and you still get a better outcome. Treatment of aspiration pneumonia has to be multidisciplinary. You need to involve speech therapists, ENT, occupational therapists. You need to talk to patients and family members to educate them. You need to do a good risk assessment for oropharyngeal aspiration. This is something you need to do. How many in your hospitals, do you have a program to manage aspiration pneumonia? That's a major bulk. In the medical floor, this is a very common problem. We don't have protocols. We don't have a clear guide pathways of addressing this aspiration pneumonia. It depends upon the consultant if he wants to call, and it's quite of a fractionated care when it comes to these populations. Yet I showed you that they have a very high mortality, they have a very poor outcome, and still we are not addressing those particular populations. For previously mentioned patients, which antibiotic would you recommend? Now, when it comes to antibiotic, I need you to remember one thing. If you get 5 consultants, ID, and you've seen this multiple times, in one room, and you ask them the questions about antibiotic, you can get, what, 25, 100 answers? It's rarely that they would agree. So I'm not challenging you here. I'm just giving you some examples, and then more than one answer might be an accurate answer, and then I'll show you where to get the evidence from and educate yourself on what would be a better options or a reasonable options. Cefazolin, first generation cephalosporin, plus metronidazole or clindamycin. Clindamycin alone, amoxicillin plus clavulanic acid, moxifloxacin, ceftriaxone plus clindamycin or metronidazole, ceftriaxone plus metronidazole or clindamycin, ceftazidime, sorry, tazobactam, and imipenem. Yeah, بيبتازو معبود الجماهير بيبتازو. It's like يعني بس على طول على بيبتازو، كله على البيبتازو. طيب.
Dr. Salim, one minute. Yeah, about toxoplasmos, it's showing Dr. Salim that we must not use this except for as much as we can.
طيب.
Because especially in our country, endemic disease, and sometimes we have active like so. Don't give it unless in very cases. Just for a specific case.
Concur with that. Totally concur with that. The point I'm trying to make here is respiratory quinolones have anaerobic cover. And the point I was trying basically to make is people sometimes would still use, though we would not recommend, but you will find patients on levofloxacin, moxifloxacin, and they are adding on top of that flagyl. Those drugs have an anaerobic covers, and you don't really need to add, you don't make it more complicated by adding flagyl and clindamycin. But totally agree, you should probably spare those drugs to TB. So,
what about adding vancomycin to nutrition for the possibility of metacardial vancomycin plus peptazole?
who would put vancomycin?
And a good point to understand 15% of the population from mucus, because sometimes people can. It's a good point.
Who would put it from day one?
Or we nasal it maybe.
It's even worse now. دخلنا لموضوع اللي نازل. So let's stop here. Who would put it first? Who would first from day one will add clindamycin? No, sorry, vancomycin. Who would add it from day one? Good, the case is settled. Only one person.
So you, maybe if you have
But all right. Your choices has to be. Your choices has to look into many considerations. Whether this is an aspiration from a healthcare communities, from hospital, what is the local resistance pattern, what is the severity of the illness of the patients, whether the duration of hospitalization was prolonged, what is the increased MDR colonization risk, structural lung disease, ICU, yes, ICU admissions, drug that can change the pH. So this is basically summarizes this. Aspiration pneumonitis, you don't treat. Aspiration pneumonitis with signs of symptoms lasting more than 48 hours, you can give ceftriaxone. Omit the respiratory quinolones, though you will see it. And the fact that not everybody deals with a similar community here, but you will see respiratory quinolones. Aspiration pneumonias with nasogastric tube or bowel obstructions or use of acid suppressive agents for a long period of time, ICU admission, third generation cephalosporin, you can choose tazocin as well. I'm not a fan of using tazocin very early. Community-acquired aspiration, ceftriaxone. Hospital-acquired aspiration, third or the fourth generation cephalosporin. If you use a fourth generation cephalosporin, some people may add flagyl on top if they think this is involved. There is an involvement of anaerobes. Now, clindamycin and flagyl should probably be reserved for the last group, which is severe periodontal disease. If you think there's a severe periodontal disease, sputum, smell, perturbed sputums, or presence of alcoholism, because those patients have a higher incidence of.
I'm sorry, so that you all work on this. And basically made a statement which is the literature. Quinolones and the quinolones have okay coverage for anaerobes. The community is expecting anaerobes to add a better anaerobic coverage.
No, if among where does it? On which one? On the last? No, but this is the last. The last is a very no. The severe if you have a severe periodontal disease and perturbed sputum, the involvement of anaerobes are probably more, and the spectrum of coverage of the quinolones may not be enough in these groups. Yes, but this is only on the last group of patients. Only on the last group
Discuss to the audience
of patients.
when you have severe anaerobic infection, you don't count until the onset.
On the last group, but you need to have some other identification, because most of the aspiration we see in the common medical floor do not belong to the last group. Now, clindamycin or metronidazole is active on virtually all clinically important anaerobes, but it has minimal activity against most microaerophilic anaerobic streptococci that are found in a lot of aerobic lung infections. So clindamycin is the drug of choice if you have a lot of these features to suggest pneumonia. We prefer it over flagyl.
Yeah, actually, even in Canada, they used to say clindamycin is good for infection above the diaphragm, and it uses anaerobes.
Below the diaphragm. Yeah.
Come in, that is advocate. If you think about clindamycin failure in lung abscesses.
Yes.
Think about that.
But this is clindamycin is better than penicillins for lung abscess. However, comparing to beta-lactams, drugs like tazobactam, there's hidden different literatures. Some people who actually say clindamycin on a higher dose will be good as a single agent even, but most of the people will not use clindamycin alone if you have an abscess. And they will add to that, especially in this population, elderly, not the young populations, they will add to it drugs like ceftriaxone, beta-lactams, or they would use one single drug like piperacillin, tazobactam. One more case. 58-year-old woman admitted for an elective cholecystectomy, non-eventual operative course. Post-operatively, she was on cefoxitin for 48 hours. Day 12, high-grade fever. 39, shortness of breath, dry cough. She said she's been having diarrhea for 3 days prior to that. She has severe headache. Clinically confused, facial twitches and tremor, respiratory rate 45 per minute, blood pressure 88, heart rate 116, saturation 77 in room air, increased to 90% on 100% oxygen via face mask, crepitations bilaterally, right more than left, dullness right lower lobe, hypoxemic, sodium 127, potassium 3.5, urea high, creatinine high, CPK is high, white cell count is 2.5, platelets 105, ALT is a little bit high, ABTT is 65. Pneumonia, admit to the ICU, in 48 hours, 72 hours, intubated, multi-organ failure. Blood culture is negative so far. You are on day 3. Sputum have shown 25% epithelial cells, less than 10 epithelial cells, so more than 25 WCs. No organisms. Urine is positive protein, and 1 positive for blood, and the culture is negative. Remember, we are an ID meeting, so don't think outside the box. Don't think of all other non-infectious causes. Remain in the box of infectious. What is the organism? Fine. Anybody has, based on the history, a clue what could be the one that I'm looking for? Which choice of antibiotic would you use? Tazobactam plus vancomycin, imipenem plus vancomycin. Tazobactam, those who love tazobactam would love this slide. Tazobactam plus moxifloxacin plus vancomycin, tazobactam plus azithromycin is everywhere. Colistin plus meropenem, imipenem plus vancomycin plus caspofungin, tazobactam plus tigecycline. That was the question initially. Huh? Which one? Third and fourth, tazobactam plus moxifloxacin plus vancomycin, and 4, which is colistin plus meropenem. Huh? This is the case. If I'm telling you what we are treating, khalas, finish, I'll just step down. I don't know. I'm assuming whoever answered on 3 knows what he's looking for. Story again? طيب, 58, you'll compensate me for this time though.
You take more time than what you
Now I'm supposed to finish 10-10, right?